Hello and welcome to the MOOC. My name's Dr. Simon Bignell. I'm the lead academic on the MOOC. Welcome to this first unit, ADHD, Attention Deficit Hyperactivity Disorder, and Hyperkinetic Disorder. We'll discuss in part the differences between those, but essentially we're talking about the same thing. I'm going to very briefly cover some of the content that we've put down on the MOOC for you in terms of stuff you can read and videos you can watch, and hopefully tease apart some of those more enduring questions that might come up for you. I'm going to stick closely to the material that's available in the MOOC so we can map on to that. I'm going to refer to some of the core text in terms of the structure. I'll just work through it. So one of the first things I wanted to do was just to flag up how you can get more involved in finding out more about autism, Asperger's and ADHD, not just this particular unit. We've put up this hashtag here, so hashtag AAAMOOC, M-O-O-C. So if you're a person that likes to tweet, if you're into Twitter, then you can certainly use that. There's already a ton of stuff there put on the Tweetosphere, however you want to refer to that. If you want to contact me and direct tweet me, you can contact me at Milton Broom, which is my handle. Don't ask about the name, it's a long history there. Feel free to join me in the discussions as we move through all of the MOOC itself. So let's focus in then on today's remit, which is to look at ADHD and hyperkinetic disorder, to move through some of the larger issues surrounding this big topic. You will, of course, be aware that we have a talk with Dr. Tony Lloyd, the Chief Executive of the ADHD Foundation. You may have already watched that. Absolutely brilliant. The services that organization are offering are cutting edge, so I can highly recommend their website, and links are available on the MOOC to that. So the big question for us then, what is ADHD? What is Attention Deficit Hyperactivity Disorder? Well, if you follow the MOOC materials, you'll soon come to standard definitions about hyperactivity, impulsivity, and inattentiveness. Mainly, this is defined by the diagnostic criteria, so those diagnostic manuals that specify the amount of symptomatology, so the amount of symptoms you have to have before you can go on to get a diagnosis of the disorder. Now, this is slightly different between ADHD and hyperkinetic disorder. This is probably a good place to bring up Jess's question on the forum. She says, hi, after completing module 1 or unit 1, I'm still unclear as to the distinction between ADHD and hyperkinetic disorder. Can someone please clarify the difference between ADHD and hyperkinetic disorder, or are these terms used interchangeably to represent the presentation of the primary characteristics? Well, thanks for that great question. This is really critical, really, to a fuller understanding of what these conditions are. Now, they're not the same. Often the term is used interchangeably, absolutely, but since about 1987, it's been known as ADHD, Attention Deficit Hyperactivity Disorder. But the World Health Organization in 1992 coined the phrase hyperkinetic disorder. Now, you can view the World Health Organization's diagnostic manual, that's the ICD. That's the International Classification of Diseases. It's now in its 10th revision, as a sort of on par with the DSM, which you'll probably be familiar with by now, which is in its 5th revision. So that's the DSM-5 versus the ICD-10. A little bit technical in terms of these diagnostic manuals, but essentially these are the books that psychiatrists look at when they want to know what are the criteria that have to be fulfilled for diagnosing a person with ADHD. Or in the case of the ICD, what's known as hyperkinetic disorder. Now, with the ICD, hyperkinetic disorder, there's a little bit more of a narrower definition of ADHD that it can be said includes more serious cases. There's also the way of viewing this that it's more to do with the disruptive behavior. So ADHD used to be classified as a disruptive behavioral disorder, and in the DSM manual categorized as that. In the ICD, there's some historic characteristics of how the DSM used to classify ADHD as well. But in the DSM, you've got 3 primary subtypes or presentations. These are ADHD in its combined form with both inattentiveness and hyperactivity and impulsivity. And then also 2 other subtypes, which is predominantly inattentive type and then predominantly hyperactive impulsive presentation. In the ICD, that's a slightly different way of characterizing it. You don't see these subtypes come out so clearly, but you still have to have certain amounts of symptoms of both inattentiveness and hyperactivity and impulsivity as well. So there's a subtle difference there. In Europe, psychiatrists, pediatricians, doctors who are specialists should be, by definition, using the World Health Organization diagnostic criteria. However, that doesn't represent the majority of research findings that rely more heavily on the DSM, the American Psychiatric Association's diagnostic manual. So I don't want to get too much into these different specifications for the diagnostic criteria, just to say that if you want a fuller understanding of ADHD, you should also have the academic knowledge surrounding the diagnostic criteria, as well as a lived experience view of what ADHD is. So for this, I think it's best to go to the National Institute of Health and Care Excellence, or NICE's way of thinking about ADHD. And they describe it as a heterogeneous behavioral syndrome characterized by the core symptoms of hyperactivity, impulsivity, and inattention. So while these symptoms tend to cluster together, some people are predominantly hyperactive and impulsive, whilst others are principally inattentive. So you can see there's a segmentation there between the hyperactivity and impulsivity and the inattentive form of ADHD. We see this in the diagnostic criteria, and it's important to remember that not everyone with ADHD has all of the symptoms of ADHD. So think about hyperkinetic disorder and attention deficit disorder as being this mix of different profiles that are represented in people in different ways. So the symptoms, if we want to think of them as symptoms, and again we sort of buy into the more medical way of thinking here, represent those underlying characteristics that must be identified to go forward and get a diagnosis of the disorder. So you can think of them as the core underlying symptoms, or the primary symptoms that a person must have to qualify, if you like, or fulfill the full diagnostic criteria there. Things like that has to have existed before a certain age. You have to fulfill a number of these symptoms. It has to exist in different settings, and it's not better described by another psychiatric disorder. And the clinical case history perhaps is the one thing that informs a diagnosis and assessment, and that process of coming to understand whether a child actually has ADHD or something else, or indeed is just presenting the symptoms on a continuum, if you like, that represents sort of an extreme of normal behavior. So where the line crosses into pathology is really one of the hot topics for you studying the MOOC at the moment. Where does normal boisterous behavior become a pathology, a psychiatric disorder that needs appropriate treatment there? So ADHD is a developmental disability with a childhood onset, and it typically results in a chronic and pervasive pattern of impairment. That means that it's really bad and it crosses different domains. The school, social domain with their children's friends or adults, sort of peer network, and in the work domain later on in life. And that's equally appropriate for children earlier on in life, of course, as well in school, which essentially is the same as their work domain here. So it represents a pervasive and chronic developmental disorder because it gives the child a disadvantage in engaging with the school system, making friendships, maintaining friendships, and also in their communication as well, which is a common comorbidity, which we'll come on to in just a second. So ADHD isn't a new disorder. As we understand it, ADHD has been described in the clinical literature for well over 100 years now. And in the MOOC, I write about this history of how it was first identified. It's been known by different names throughout the years that we've come to understand and narrow the definition to be more specific in pinning down exactly what is and what is not ADHD. So let's just have a look at some of the symptoms then first. So one of the first things you must realize is that you have this sort of a three-part symptomatology around ADHD: hyperactivity, impulsivity, and inattentiveness. And any of these different areas of ADHD can impact on a person's lifestyle to the detriment of their lives in different ways, in different degrees of severity. So inattentiveness then, or inattention, is a key characteristic. But our recent understanding in terms of theorizing about ADHD characterizes ADHD as a disorder or an impairment of executive function rather than one of purely of attentional mechanisms. So how we have come to understand ADHD now is much more as a brain-based neurological condition rather than one of purely the inability to attend to certain things or hyperactive impulsivity, being up and out of your seat here. So now we understand ADHD as a brain-based condition which has a genetic susceptibility, which gives you a vulnerability to acquire the disorder as one moves into more challenging situations. So often ADHD won't be recognized very early on in life, but when a child comes to the going to school years, there's a natural control group there, isn't there, around the age of about 7, where there's a natural comparison with the children in the classroom. So for a child with ADHD, they're often considered much more up and on the go, out of their seat, much more talkative, interrupting the teachers, essentially much more disruptive, which can flag them up for a referral to CAMS, Child and Adolescent Mental Health Service, or certainly the special educational needs school system that's in place at that moment. So although inattention can be a key characteristic of ADHD and is one of the clinical markers, it's not the be-all and end-all of the condition here. Hyperactive behavior and impulsive behavior are often go hand in hand. So these are equally frustrating for a child with ADHD. And the consequences of this can be demonstrated in their behavior, their everyday behavior, that is, that they can be impatient, frequently talking, have difficulty sort of delaying their responses. They can fidget, always sort of tapping their knees, squirming in their seats, running and climbing at inappropriate times. Now, this is different from the everyday sort of behavior we see in the schoolyard, where they're running around enjoying themselves, screaming out and doing what kids do well. This is out of place behavior that can't be controlled. So it's difficult to delay that inhibition there, or delay that response in light of competing stimuli, to focus in on one thing, set aside another, deal with that thing, then come back to the thing you're dealing with. So Russell Barkley, the key theorist in the field, will talk about this a lot in any time he mentions ADHD. So we can characterize the condition as one of executive function. The primary executive function for us in consideration of ADHD then is that of delaying an ongoing response, or what Barkley will call response inhibition. So you can think of one of the causes of ADHD, at least the demonstration of the outward manifestation of ADHD, as being the inability to stop yourself and then carry on with an appropriate train of thought or activity. So to be able to stop yourself or inhibit yourself in one train of thought or action to cope with other competing stimuli is seen to be one of the key executive functions that underpin all of the other, like working memory and so on and so forth, that you can read about in the MOOC. We cover this in later sections, in later units as well. So let's move on then to the consequences of ADHD. We've seen that the symptoms of ADHD themselves can impact in various different ways, but the consequences of having ADHD can be considerable for the person, not just the child themselves, but later on in life as an adult. It can lead to a vast number of negative consequences that interact with one another. So the combination of perhaps inattentiveness and impulsivity and hyperactivity, can lead in childhood to what's called a developmental lag of about 2 to 3 years. So the child can be behind on things like their educational attainment and performance. They can fall behind in SATs tests. They're the regular tests that kids used to get, and their performance can very much fall off. Now, later on in life, they tend to catch up, but the impact of having ADHD in terms of the chronic symptomatology there can manifest in different ways. Later on in life, it can lead to failed relationships because of the behaviors that can emerge because of the hyperampulsive traits, characteristics, markers, indicators. Impulsive decision making can lead to bad financial management, getting into debt, making choices in life that perhaps aren't the best for oneself in hindsight. So this impulsivity that often is underpinning good problem solving, the ability to just set yourself back for something, consider it, and not go down that impulsive route and take the that train of action that one might do in a more spontaneous way there. So in the real world, we can see the manifestation of particularly hyperactivity and impulsivity is leading to a number of negative consequences, just some of which I've sort of indicated there. The prevalence of ADHD is really important to know about. It's difficult to pin this down because different research papers claim different prevalence rates. Some epidemiological studies claim up to about 5% of school-age children have ADHD, slightly less diagnosed with ADHD in the UK, more so in North America. So different local authorities also have different rates of diagnosis. So different counties of the country, in those counties you'll see different rates of diagnosis cropping up depending on things like local policy, the availability of child and adolescent mental health services or private services that are engaged in diagnosis or assessment. Also, schools differ in the rate at which they make referrals out to people like educational psychologists, bringing in external help. So although this figure of about 2 to 5% of school-aged children in the UK is put around, the real figure is, at the moment, is unknown. We don't have a reliable database that informs that. What we do know is there are sex differences in ADHD. Boys are much more likely to be diagnosed with the disorder, as so with ADHD, autism, Asperger's, and many other developmental disorders as well. So boys are up to about 6 times more likely to be referred for assessment, slightly less in actual diagnosis there, but the exact ratio of these traits might be closer to about perhaps 1 in 3 girls for every, 1 girl for every 3 boys, as it were. We just simply don't know. There aren't any reliable studies on this at the moment. And because ADHD is diagnosed primarily on behavior, taking a clinical case history, it's the externalizing behavior that seems to get people referred for help, much more so than perhaps a more quiet, inattentive girl who's sitting at the back of the classroom goes under the radar. Perhaps more girls are undiagnosed with ADHD than boys. So there's a lot of hot debate at the moment, controversial debate going on about the sex differences in ADHD. So that brings us on to comorbid conditions. Comorbidity is one of these weird psychological terms you may or may not be familiar with. This is to do with conditions that often occur with ADHD. And they can be independent and they can be related to the core underpinnings of ADHD. Certainly as a separate diagnosis that goes hand in hand with ADHD at the same time. You can think of these comorbidities as separate diagnosis which may or may not be diagnosed. It was the case previously within the DSM-4, which was the previous iteration or the previous version of the diagnostic manual that most people use in research, that you couldn't have a dual diagnosis with, say, things like autism or other conditions like schizophrenia, for example. Now in the DSM-5, which is it's been brought out in 2013, you very much can do. So this dual diagnosis allows us to treat both conditions, for example, anxiety, alongside and equally with ADHD. There might be a co-presentation of different conditions, like oppositional defiant disorder, conduct disorder, obsessive compulsive disorder, a major episode of depression, or even dysthymia, which is perhaps can be seen as a milder form of some of the depressive symptoms. Pragmatic language difficulties, dyslexia, all of these are often cited as being highly prevalent when you have one condition, another condition is more likely to co-occur. So the comorbidities also interact with the condition's symptomatology. So you might be inattentive, and that might impact on your dyslexia, for example, or you might be impulsive or have the hyperactive traits, which can impact on anxiety. So if you're continually not able to make friends because of your hyperactive, impulsive type behaviors, might lead you to feel there's something wrong with yourself, might have a knock on your self-esteem, might lead to depression or anxiety, for example. So it's really hard to separate into discrete sections comorbidities as they arise in ADHD. There's always an interaction between the conditions. That's making the life of clinicians more troublesome, because how do you treat one thing and not the other? If there's a primary diagnosis, perhaps you'll treat that at the fore and use appropriate interventions. These might be psychopharmaceutical medicine, for example, or behavioral, in terms of a behavioral therapy or strategies that you might use. But at the same time, you might use other interventions for, say, anxiety, or depression or something like that. So it's really, really important to consider the child as an individual and not see them as the presenting condition, and just think that's a case of ADHD. The person themselves and the things like their personality traits, their individual differences, account for much more variance in what you'll get in terms of the symptomatology coming out that you can treat, that you can put in place separate strategies and interventions, than just thinking of these core underpinning symptoms. So if you're a person who comes into contact with children who have a diagnosis of ADHD, it's really important to think about how comorbidities and your diagnosis can interact with the person's personality traits, with their characteristics, which make them, individual in their own right. So what we try to get to is a more holistic form of understanding the person alongside their impairments, which we might choose to classify as a diagnosable disorder. So in later units, we refer to the causes of ADHD, and I don't want to go into too much detail about them now. There'll certainly be ample room for us to have a discussion about that later on. The diagnosis of ADHD is, to an extent, different up and down the country. The immediate pathway is through a GP, a referral to a child and adolescent mental health practitioner, pediatrician, effectively a child psychiatrist. The idea is that the child suspected of having ADHD should be referred to a medical practitioner. What we want to get to is professional help, someone who is best placed to inform that process of diagnosis. And the school special educational system is the best way to access that available help. So I'm aware of time now. I just want to move on then to a consideration of the MOOC itself in terms of the stuff I want you to cover. I really want you to get hold of the idea of ADHD as a developmental disorder which affects thinking and behavior due to underlying problems of poor attention, hyperactivity and impulsivity. It's linked to long-term adverse consequences because of that symptomatology. It's not a new condition. It was first described about 100 years ago. The prognosis is wholly good for, especially for children who are diagnosed relatively early, where we can get interventions in place to make adjustments to the school education system there. So please get stuck into the MOOC's material here. know that there are generally good outcomes for children suspected with and diagnosed with ADHD. Know that there are sex differences there. A lot can be done in terms of the interventions, behavioral or psychotherapeutical, in terms of medication or other interventions we can put in place there. I'd really encourage you once again to get involved with the tweet stream, get stuck into that, and to continue to contribute to the forum as well. If you do have any questions, please raise them on the forum, and we'll do all we possibly can to answer them for you. And I look forward to listening to your questions and comments on the forum and engaging with you in that way. And I look forward to making Unit 2's content as well. So I'll catch up with you then next week and wish you the best of luck with this material. Thank you once again.